So I'm Neil Walker. I'm the Chief Data Officer of Gut Reaction. I'm also the Clinical Bioinformatics and Statistical Genomics Manager at the NIHR Bioresource, a job title meant to put everyone else off. Right, so a couple of things before we begin from what's come up already. I urge you to go and look at Baroness Honora O'Neill's TED talk on the difference between trust and trustworthiness. These things get confused, and she is very clear. And secondly, I'm very happy to talk to people afterwards about discussions I had with Phil Booth and Palantir in the same room, which was quite interesting. Phil Booth being the guy behind Med Confidential, who is not as fundamentalist as some people say about ultra-privacy. So we are different to some of the other trusts because we are dealing with consented participants throughout for whom we've added extra data on the basis partly of their consent. So this is the overlap of getting in healthcare records of the health of people who already consented. And one of the advantages of that, which I'll get to because this is a focus on the NHS data, is we've been able to bring free text in, which is an area which is notoriously hard to depersonalize. And again, you'll notice I'm not using anonymized, I'm not using pseudonymized, I'm not using de-identified. It's depersonalized because it can always be repersonalized. So anyway, so first of all, this was how we started in the gut reaction. In fact, it's a slight evolution because we're gathering data from lots of trusts, and this is slightly more trust than we started with, so well done for the second lot for joining in. And to Janet Valentine's point, if you do something and it's hard, do carry on doing it? It did get slightly easier getting trusts on board, simply because we began to understand the IG, and there's experience here in the room for people doing that, and we also did get slightly easier dealing with their data, but the data from every trust is different because they don't run the same systems. The old adage is, if you've seen one Epic system, you've seen one Epic system. So the two of them are not the same. So the other thing I should mention from this slide is a big up for our partners in this. AIMS has provided a data center for us, and it's very important to have a data center that you trust and that project the trustworthiness that we require. Privitar have worked with us throughout on getting the data depersonalized to a suitable standard, and I think that's important because it then means we can report back to our PPIE group that we have done the right thing by their data. So the other part of this, of course, I have to thank the trusts, and I've already met a couple of these people here this morning. We have IBD Registry, and Liz is here too. So there's lots of people to thank, and of course, it's all been managed by EAHSN. So if we move on quickly, given there is time moving, does that work? No, there we go. This is what our planned overlap was at the beginning. I assume you will see the slides, so I'll move quickly to the next bit. There we go. So we're focusing on the NHS today. Okay. And this is what's been happening with the trust. So, like everyone else has said, the pandemic came in. This is not a brilliant time to be asking trusts to provide you data. They all were kind of busy. But what it meant is that effectively, the majority of our data has arrived within the last year. And it's doubled over the period of the time. And so we have about 23,000-ish patient records representing millions of items or so in a moment. But the gradual number of increase in patients has also increased very rapidly. Trusts have been brilliant, and I think anyone who's ever run a clinical trial knows the best way to get people to do things is to pay them. So I recommend, if you want to work with trusts, you give them a quick pro bono for something. This is how we process the data that arrives. It's a bit complicated, but one of the joys of things arriving slowly is we got better at it. At the beginning, it was all a bit ad hoc because we didn't know what to expect. Because we went to the trust and said, just give us what you've got in this shopping list, and they chose to give it however they had it, which meant we got quite a range of things. But at the moment, though, we're moving into the much more organized. The cataloging works well. With much prodding, we now use the gateway quite effectively, and we're putting our data use register into there, as well as the data metadata, which I think is important, because there is no earthly reason why someone looking for data would find us and our website. But they will find the HDR UK gateway. So it's important you advertise where data is. I know Phil Quinlan's here as well for the CRC tissue directory. Again, that's another piece, and others like Paul Smith from BC for the links. So we're trying to get things together in the same way other people are. Every trust is different. One trust basically pressed their subject access request button and just sent us whatever that produced, which was a several hundred page PDF for a patient, which we then had to break apart again. Others just send us Excel sheets. Others gave us beautiful structured documents in HL7 format. All of it we had to beat together. What sort of records are available? So there's some quite big numbers on here. That's a logarithmic scale on the bottom, just so you can get the hundreds and the thousands and the tens of millions onto the same slide. So there's an awful lot of very detailed data. And again, the hot tip was from people who'd done this before, do not try and make a rectangle out of all this, you'll just go mad. So basically, you're driven by the use cases, and if someone says, I want to do this, that is when you'd say, okay, we have data like that, let's try and harmonize it. And so that's what we've been doing. So what does the NHS Trust give us data beyond what we had before? Because as I say, we had a cohort of consented participants, we had their own records, their participant surveys, we had clinical records from when they were recruited by their team, we had a load of genomics, which is great. What we didn't have is what NHS Trust gives us, which is longitudinal data and free text, which is unusual, and images. So in particular, the advantage of all the longitudinal data, and this again refers to Janet's point about CPRD and whether you could limit care.data, is you get a real sense of what came before the thing you've seen. This patient has records from before they were declared to have had this IBD, and that's very important because then maybe you can see some precursors, or you can see some immediate consequences. Particularly, we've now been asked, are we interested in pharmacosurveillance, for instance? Because that's one thing you can do with longitudinal data on patients. And the free text and images are very rich sources of data. And in particular, there is the holy grail of could you use one without the other if only you knew how to join them up. So the richer data, though, does provide closer scrutiny. So like other groups as well, we've had a fantastic journey with our patient advisory committee, which has now morphed into patient and public review group. And the idea is that they actually sit in between. As soon as we've got an application that comes in that actually looks coherent, which is what the triage step about is in that, it then goes off to the patient group to review whether it's actually sensible. And one of the things I would contradict, which I've heard several times, is we do not believe our patients will all agree. And so we're also working on methods of how they can disagree and how we can offer different alternatives to participants in studies in order that we don't just end up doing bland studies or having to use laws to get around the fact that we can't do things otherwise. So that maybe it's a question of saying, this we have to reject, this we think we can accept, this we may have to give the patients themselves an opt-out, this is so severe, it may need an opt-in. So we're actually beginning to explore that with a participant portal now on the cards. So, but the committee have been great, and they are really, really, really varied, and you cannot get a consensus out of them, which is probably right. So just as an example, first thing we have to do normally is beat everything into the same format. So this is an example of the free text. Some of it arrives in Excel, some of it had to be scanned off PDFs. All of it gets broken down into phrases. One of the things we've managed to do with depersonalizing the data is effectively you break the letters down into small enough pieces that you can be fairly confident that the pieces, if you scan through them, are not individually identifying. Because the concern, again, from our patient group was that your letters include stuff which is nothing to do with their disease. It might reference their mother-in-law or their other relatives and whatever, which is nothing to do with them. So they were very keen that we broke it down, so that's what we did. And this is the red bits are my versions of the blue and black bits, which is my data scientist versions. So effectively, we take this de-identified, depersonalized text, the clinicians actually work on it hard. It then lets the machine have a go. It then goes round and round and round, gradually building up the data set until we can be confident the computer is producing a list which is roughly matches what the clinicians think from all the data is the answer. And at that point, you can say, right, you've had a go at 160,000. Now go away and run along another couple of million. And by the way, we don't have to look at those so much. So that's the idea of this. And the reason this is a real use case is people with inflammatory bowel disease, there is a problem that they can turn up with a flare, and they can often end up with these deep vein thrombosis issues. And so the idea is, if you knew that was going to happen to this person, you could have given them an sort of blood thinner when they arrived at A&E, and that would have helped. So could you detect the people in advance? Because in which case, that is a real life case. So you've got 59 positive cases on the first round. You go around again, it'll build up, it'll go around, it'll go build up. So that's the idea of that. So, and this is the bit where I end. so I promise to be brief. So we are getting quite a lot of imaging data coming through. So this is an example from Leeds. Leeds is brilliant at this, partly because they've been the national centre for the National Pathology Imaging Collaborative, or whatever the acronym stands for. And that means that the NHS is gradually trying to digitise its images, and we've been the beneficiary of that. And other trusts are coming on board to do the same. And I spoke to John from King's, who said it was just so exciting that someone actually wanted the data. And so this is the challenge, is that each of these images is rather large, so 3 gigabytes for an image. The bit you can see highlighted, I can't even see in the main thing, so that's what's going to happen. So the idea, though, is we can put that together with other data and gradually develop use cases. I think for the small, medium enterprise who's been coming to us to do AI, it's exciting, because normally they don't get a crack at real data. They get told, you can put your algorithm maybe in a hospital, but you can't actually get at the data itself. So, and that's the end, and that's our partners. Thank you.